Good afternoon. Today I will be talking about three case scenarios of where I did an IOL exchange. Cataract surgery is no longer a therapeutic procedure as it was done in the 80s. Now it has become more of a refractive procedure. I'm just going to skip to the case scenario. So 67-year-old female came to us with a complaint of diminution of vision in the right eye since 3 months. She had already made up her mind that she had poor vision in the left eye since 10 years. She's given a past history of undergoing cataract surgery in the left eye at a camp 10 years ago. So we went ahead and she had a myopic fundus, so we did with optical biometry it came out to be +8, so we did a phaco and implanted +8 IOL. She was happy with her right eye vision, so she wanted some visual improvement in the left eye. With -12, she was able to read about 612, and optical biometry showed about +4. So this is a video I have. Since it was an SICS and it was done about 10 years ago, I made a corneal tunnel about 2.22 mm. Since it's a rigid IOL, I injected a cohesive to make sure the haptics are dialed into the AC gently. And I extended the tunnel to about 3 mm to ensure easy explantation of the IOL. And +4 lens was injected into the bag. And I closed the tunnel with infinity suture. So out of curiosity, I wanted to find out the power of the rigid IOL, which was about +21, which is why she was not able to read. So this is the post-cataract refractive surprise. The second case is a calcified IOL. These days, we're not getting these, but before we used to use hydrophilic lenses. It was quite common. She had undergone a phaco about 5 years ago, and she had gradual vision loss in the left eye since 14 months. She had visual right eye, she was reading 6.6, and in the left eye, she was reading only hand movements. Since it was a calcified IOL, we did a B scan, it was normal. And in the optical biometry pseudophakic mode, I calculated the power and explanted the calcified hydrophilic lens and implanted the aspheric hydrophobic lens. This is the third case. He's a 52-year-old male goldsmith, so he obviously had high visual demand. In the left eye, he had undergone cataract surgery 5 years ago, but in the right, he actually came to us with complaints of diminution of vision in the right eye, and he didn't want to depend on glasses to work on for his work. So he wanted a multifocal IOL, went ahead and did an uneventful phaco with a multifocal lens. And he wanted this, he was seeing well in the left eye, but not as well as he wanted, so he wanted the same visual quality in the left eye too. We did try explaining him to use the right eye for his near vision, although he wanted the same visual quality in the left eye as well. So I have the video. So this was an aspheric, good quality, probably an IQ platform monofocal, and he did want to have a multifocal in this eye as well. I use a twist technique to explant the IOL, which was popularized by Dr. Uday Devgan. So this was another patient of mine, so I just kept this video to explain the technique. The trailing haptic is brought outside, and using the McPherson, the optic is held at the optic haptic junction, and with the help of Sinsky, it is twisted and rolled out of the eye, and the lens is explanted in toto. And PanOptics was implanted as he wanted a multifocal IOL, and we had a very happy plano refractive Goldsmith in both the eyes. So the most common indications for PCIOL explantation are IOL dislocation, incorrect IOL power, that is the post-cataract refractive surprise, IOL opacification, persistent iritis, and UGH. As with any surgery, IOL exchange is also associated with its fair share of complications, the most common of which is PCR, which can also lead to vitreous loss. And if the IOL is sitting in the eye for a long time, when the lens is tugged on with force, it can lead to zonular dialysis, retinal tears, and even cystoid macular edema in the long run. So IOL exchange should only be done when the visual problems caused by the current IOL cannot be managed by non-surgical means, and each case is unique, and the decision to perform IOL exchange should be tailored according to the individual patient needs and circumstances. Thank you.